Okay, wonderful. Well, good evening, folks. Thank you very much for joining Dr. Miller and myself for this webinar on prostatic artery embolization. We do have one of our other guests who may join us shortly, Dr. Puvirappa, who is the Chief Medical Officer for Innovation and Development at IR Centers. We'll just go over a brief overview of who we are, and we'll dive right into the meat of things. I am Hisham Malik. I've been with Greater Boston Urology for about 3 years. I've been in Massachusetts for quite some time. I've trained at the Brigham and Women's Hospital for my training, and then practiced at UMass Medical Center for about 10 years before joining Greater Boston Urology. Speaking of UMass and Worcester, Dr. Miller himself, who is native to Massachusetts, to Sudbury, if memory serves me right.
Very good,
Um,
Sean.
he attended medical school at UMass and then left us momentarily for his training in radiology and interventional radiology at Duke Medical Center in North Carolina. And then home called him back, and he was up at Mass General Brigham for some time before joining us last year. So we're very excited to welcome him as a member of our team and look forward to helping you. So diving right into things, our objective today is to give you a brief overview of benign prostatic hyperplasia, which is the medical term for an enlarged prostate, talk about this procedure that has been offered at Greater Boston Urology for the past few years, go into some detail about how the procedure is performed, what we expect as a result of the procedure, and common questions that folks have about this procedure. You may have noticed that I talked about us as interventional radiologists. You may have caught that briefly. Interventional radiology is a distinct specialty in medicine that works alongside experts such as those at Greater Boston Urology, work alongside our urology colleagues in the evaluation and management of folks with a variety of medical conditions, specifically for today, an enlarged prostate, but it's a specialty that has expertise in diagnostic imaging as well as the ability to deliver care through minimally invasive approaches, one of which is prostatic artery embolization. So BPH, as some of you may know, is a condition that is increasingly being made aware of due to its effects on an aging population. And so the prostate is an organ that sits at the base of the bladder and helps in sexual function. As one ages and it grows, the pictorial on the left shows that it can compress the urethra as it exits the bladder and can cause difficulties with voiding. Normally, when we evaluate patients who have difficulties with voiding, specifically with prostatic enlargement, is that they may have symptoms that we call irritative or symptoms that are obstructive. So things like having to go to the bathroom multiple times, the urge to urinate constantly, having to go multiple times at night to the restroom, having accidents because you're unable to control your urge to urinate, noticing a weak stream. It's not as strong as it was when one was younger. Difficulty starting a urinary stream, stop-start urination, and in some cases, the complete inability to urinate, which is called retention. The pictorial at the right side of the screen shows you that we try to objectify these symptoms with a symptom score that some of you may be aware of when you visit our colleagues in the urology office to determine how severe your symptoms are. And depending on the severity of those symptoms, we decide on what mode of treatment may be applicable for you. This is, of course, important because this affects a lot of men in the United States. Statistically speaking, half the men above the age of 50, going on to 80% of men above the age of 80 develop an enlarged prostate. And there still remains a social stigma in seeking care for symptoms that affect folks. And this is an effort to ensure that those who do need the necessary care are aware of the treatment options, um, whether they are minimally invasive or involve a more invasive strategy. You may often notice the size of the prostate being compared to different objects, whether they're inanimate like a ping pong ball or a walnut or a clementine and so on. And so the idea here is to try to objectify what that means. And so a normal um, prostate is approximately 25 to 30 cc's, which is the size of a walnut. And as it grows, you can see the pictorial representation of how a walnut affecting the urethral channel that allows you to empty the bladder versus something like a tennis ball, which is 5 times the size of a normal prostate, can affect your ability to urinate. There are multiple options, some of which are not included here, that are also offered at Greater Boston Urology in terms of surgical options. Some of the ones commonly that are talked about are Urolift, Rezūm, aquablation, and of course, prostate artery embolization. To go over that very briefly, the top left here shows a prostatic urethral lift, which is the delivery of implants through the urethra, meaning going through the penis and pushing away prostate tissue that is obstructing the urethral channel, allowing one to be able to empty the bladder easier. The one on the top right is a depiction of the Rezūm procedure, where again, going through the penis and introducing a heat probe, one delivers steam-based therapy to the prostate cells that allows those cells to die and allows the prostate to shrink over time. The bottom two pictorials here demonstrate a more invasive aquablation surgery that is performed in the hospital setting and requires often an overnight stay. The prior two procedures I mentioned are outpatient procedures performed by our colleagues in urology. Back to aquablation, this procedure involves high-speed water jet delivery that pulverizes prostate tissue. And so, as the pictorials show, this is a more invasive approach and is able to affect a really good outcome with good longevity. And so how is prostatic artery embolization different from these other procedures that I mentioned briefly? As has been our practice, we enter a vessel typically at the top of the leg near the groin. This is performed in an outpatient setting, which means that you go home the same day. And so in this pictorial, we have accessed a blood vessel at the top of the leg called the femoral artery. We snake in these tiny devices that are thinner than a piece of spaghetti to the blood vessels that feed the prostate, and then inject them with these microscopic particles that serve to block the flow of blood to the prostate. And if you were to imagine yourself as these tiny catheters going from inside the vessel, this is what this short video demonstrates. This is almost like being a sniper, to be quite frank, because you are avoiding all the bad actors as it relates to embolization. You don't want the particles to go to organs like the bladder as depicted here, or to the other surrounding organs. And using one's expertise in imaging, as I referred to, as we do as interventional radiologists, and our ability to deliver selective treatment, we're able to direct that towards the prostate. This next video shows this quite well. This is shared by Dr. Puvirappa, who's kind enough to just join us now. And so what happens in the procedure is what you're seeing here. On the top left is a capture of what happens outside the drape, where you're unable to see as the patient. You're laying flat on a procedure table while the the femoral artery is accessed. And as you see this fast-forwarded X-ray, the steps to accessing the artery and treatment involve guiding these devices under X-ray guidance and evaluating where the corkscrew or serpentine or snake-like vessel that is depicted by the prostate artery comes into view at the bottom of the screen. This is fast-forwarded, but it demonstrates to you, the different paths that we need to take to carefully select this vessel. And I'll let this play one more time so that you can just appreciate that. This, I believe, was performed by Dr. Pubidapa, who kindly shared this as well. And so here this shows a pretty large size gland, which is about 100 grams or so. And so while we're performing the procedure, we use X-ray dye as well, which allows us to see how well we're performing the procedure. This particular example shows us treating the left side, and then we would repeat this at the same time and treat the right side as well. So you're going through one tiny incision and treating both sides of the prostate. Okay. Moving on a little bit quickly to, how do we know that we're doing the right thing? And part of the advantage of working as interventional radiologists alongside IR centers, as well as Greater Boston Urology, is that a lot of the research has been performed by pioneers who founded the IR centers. And so there have been multiple randomized control trials, which is the very high standard to which medical research is performed, has shown that the reduction in symptoms that one can achieve with embolization is very favorable when you compare it to gold standard treatments like the TURP surgery, which is the known commonly as the Roto-Rooter procedure or shaving of the prostate, which has been performed expertly for many years. And we know based on this research that the improvement in symptoms that we objectively try to assess, as you may recall from earlier in the presentation, is very good as well. We determined that when someone comes in with severe symptoms, that we're able to help improve those symptoms by over 50%. We also know based on our research that the durability of this is about 5 to 7 years, which again compares quite favorably with the other prostate surgeries. A distinct advantage also is that we know that embolization does not have any negative effect on your erectile function or your ability to ejaculate. In a randomized controlled sham study where one is performing an embolization against doing nothing or a sham procedure, we've also shown that this performs very well. At this point, I think I'll let Dr. Miller take over and talk about what happens after the procedure.
Excellent. Thanks, Asham. So following the procedure, we'll hang on to patients for 1 to 2 hours. That's to make sure that the arterial access we had from the case is healed up well, make sure sedation washes out all right. And before you go, our nurses will go over all the medications you'll be taking afterwards, which we have a standard regimen patients will typically take for about 5 days afterward. It's normal to have a small amount of discomfort at the site, not unlike a bruise, but typically it's very manageable. Over-the-counter pain medications that'll be a part of that post-procedure regimen will help with that. Because you are getting sedation, even though it is not general anesthesia, there's no breathing tube or anything like that, you are getting sedation, and someone would have to drive you home after the procedure. Thanks, John. So as far as recovery afterwards, so first off, the only real restriction after this procedure is that we want you to avoid heavy lifting for 5 days. And again, that's to ensure that our arterial access heals up well and that there's no bleeding from that site. So normal activities like walking, going to the grocery store are fine. Anything like shoveling snow, chopping wood, going to the gym, we'd want you to wait at least 5 days to be safe there. As far as recovery, when we embolize the prostate, stopping blood flow to it, the body's response is actually to cause inflammation. So symptoms will typically worsen for 5 to 7 days. So patients will say, I'm going to the bathroom more often. They may even have some mild discomfort with urination. The medications we had you take afterward are to mitigate that, but still it's normal to have those symptoms for about 7 days. In rare cases where patients have experienced urinary retention before, they require a catheter, or if we know they hang on to a lot of urine, typically about a half liter, there's a small risk of this procedure and the inflammation right after causing retention. That risk is still only about 10% in patients who've had it before. Patients who haven't had retention or have a high post-void residual, that risk is very low. As far as when to expect results, because we are depending on the prostate shrinking and softening, it doesn't happen right away. Typically, about 3 weeks is how much time you need to start seeing shrinkage of the prostate and improvement in symptoms. those changes should continue to improve out to 3 months. And at that point, we have a pretty good idea of how effective this treatment will be for you. Good. So we'll have a Q&A at the end of this, but just to address some common questions that reasonable people would ask. So is the procedure painful? No. The only part of the procedure you can sense is when we're getting access to the artery. Before we do that, we numb it up with lidocaine, and at that point, you've already gotten some sedation medications. All of the wire and catheter work that Dr. Malik was showing, you can't feel any of that. So the sedation is really just to help you relax in kind of an unusual setting for the 30 to 60 minutes the case takes. What are the risks? I kind of alluded to them already. One, arterial access. It's a high pressure vessel. We need to be careful how we enter and how we close. All that said, there's still about a 0.2% risk of bleeding from that site, which can usually be managed conservatively. But again, it's a small risk when you're working with experienced operators. And as Dr. Malik mentioned, when we're doing the embolization, we want these beads going only to the prostate, not to any of the adjacent organs. When we are doing the procedure, that is sort of front of mind once we're in a treatment position. And if we sense that beads are not going to go where we want them to go, we change course. Do you have to go through the penis? No. Like Dr. Malik said, it's about a 3 millimeter incision in the upper thigh to give us access to the femoral artery. Will I be able to stop my prostate medications? So a lot of patients ask this because, they're good medications, but they can come with side effects, malaise. Some patients report headaches with Flomax. Generally, yes, at the very least, we can reduce dependence on these medications. Typically with Flomax, we'll have you stay on that for about a month after the procedure. Reason being that, again, it takes about 3 weeks to start seeing changes from the procedure. And we don't want to sort of leave you high and dry without any kind of treatment for the prostate. Typically finasteride or dutasteride, which work differently, those can typically be stopped right away. Is PAE covered by insurance? Largely, yes. It's a procedure that's been around for about the past 10 years and done more frequently in the US in the past 5. It took a little bit of time, but in 2023, the American Urologic Association added it to their guidelines for the treatment of BPH. So in addition to medication and to all of the transurethral surgeries that they performed, PAE is now in those guidelines. And once that happened, insurance began to cover it. So it's routinely covered by Medicare, and most major insurers will cover it as well. Prior to scheduling, we go through prior authorization to ensure that, but generally we have very good luck getting this procedure covered by insurance the same way that any other prostatic surgery would also be covered. What should I do to prepare for the procedure? You don't really have to do much. We typically have patients avoid eating or drinking anything more than small sips of water for 6 hours before the procedure so that we can give you sedation. And in addition to that, our nurses will typically give you a call 1 week before the procedure to make sure you've received all your medications that you'll be taking afterwards. Talk about any medications you might need to hold before the procedure. For instance, some blood thinners we'll have you hold for a day or so, and what to expect afterward. How long will it take before I notice improvement in symptoms? Again, typically about 3 weeks. For patients who come in and have a catheter in place already, they've already gone into retention and they need a catheter, typically we'll wait 2 to 3 weeks for the same reason. It takes about that much time for the prostate to shrink. If you imagine you have a house plant at home, you forget to water it, it's not going to shrivel up right away. It takes a little bit of time. The prostate is no different in that sense. How long will improvement last? Like Dr. Malik said, the data we have suggests out to 5 to 7 years, there's a good durable response to this, success being over a 50% reduction in symptoms, which is similar to a lot of the transurethral therapies. The reason it or any other surgery is not 100% forever is the prostate is fed by a metabolite of testosterone, which as long as you're around, you're going to have. So the prostate is going to look for ways to grow back. So 5 to 7 years is kind of, about what we expect for most treatments for the prostate. Can the procedure be repeated? Yes. Yeah, 5 to 7 years. If your symptoms come back, it is certainly something we can do. If you notice that if your symptoms come back sooner than that, say in 1 or 2 years, we might think about one of the transurethral therapies that our urologists do. But if you get a good response for those, 5 years or so, it can absolutely be repeated. And when can I resume normal activities? Typically, again, just to make sure that arterial access heals up okay, we say 5 days of somewhat reduced activities. But again, the next day you can be up and walking around, going to the store. I often tell patients to take a couple of days off of work just because you will be going to the bathroom more often. You may have some discomfort. If you were planning on traveling, we typically like to have you stay around for 10 days just to make sure you're through the thick of those symptoms and make sure you're doing well. But as compared to the more invasive options, recovery is really pretty straightforward.
Okay, I'll stop my share at this time. I just wanted to welcome again Dr. Pavitappa and would like to invite any comments from you as well. Thank you.
Yeah, sorry. Thanks for having me. A little technical difficulty. I was in on as an attendee, but thanks for letting me come on as a panelist. You guys did a phenomenal job. I think the other points, just to reiterate, Dr. Malik and Dr. Miller really brought those points home. But day procedure done in the office. You're with us for about 4 hours. Get here about an hour before. Procedure itself takes about an hour. Recovery for about 2 hours. Can't drive, but there's no significant downtime. It's about 5 days, no heavy lifting, nothing at the penis. There's no issues with erectile dysfunction, sexual dysfunction, no significant risk for any type of incontinence. Um, can be repeated. Another big point, can last 5 to 7 years in all comers. Some patients it lasts longer, some patients a little less. It doesn't matter the size or shape of your prostate. No one's truly contraindicated, meaning they cannot not have the procedure based off of size or the shape of the prostate. Whereas some of those other procedures that Dr. Malik mentioned earlier in the presentation, they're limited based off of the size or the shape of your prostate. You guys are fortunate enough with GBU that they really offer all the procedures for the prostate, so you can really get a treatment that's best for you. But yeah, so here in the comments, I just got a question. We just got a question. Are there any prostate size limitations? So are no prostate size limitations. The one caveat to that is smaller glands may not do as well. So you may bring down that clinical success. But really, that's the case for almost all the MIS or minimally invasive procedures for um, treatment for a prostate. Another question that we got was, can it be formed while on warfarin or other blood thinners? Ideally, like Dr. Miller mentioned, we hold the blood thinners, but we have patients who are really sick and we can do it while they're on blood thinners. Obviously, they're at slightly increased risk, but it's not an absolute contraindication or doesn't mean that we cannot do it.
I can answer a couple of
Ye-
these questions here. So one, what particles do we use? It depends. Typically, it's regardless, it's going to be a biologically inert plastic. It's either a polyethylene glycol or a PVA derivative. They basically lodge themselves in the terminal arteries of the prostate and they stay there. They don't interact with tissues. They don't go anywhere or anywhere else that we'd be concerned. Next question, what about retrograde ejaculation after the procedure? Again, one that we are typically do not encounter with this procedure, just in that we're not manipulating any tissue itself. We're just decreasing the size of the prostate and causing softening of it.
I think a lot of these questions are asking, can you have PAE if you've had other procedures like HIFU, TURP, green light, and yeah, why don't you take that, Dr. Miller?
Yeah, absolutely. No, and oftentimes a good number of patients, these are who we see, there are no procedures that precede this that would be a contraindication to us doing this. So if you've had a TURP, green light, any of those things, we can still perform PAE. And vice versa is true. If we do this procedure, if down the line you wanted one of those are also still options. They're just very different approaches to the same problem, and they are far from mutually exclusive.
One question in the chat here is, I already have for erectile function and ejaculation. Will it be restored? I think that erections, you're not gonna leave with anything better than what you came in with, unfortunately. If that was the case, yeah, we would probably be a lot richer than we are now. But with ejaculation, if the cause for the retrograde ejaculation is related to medications, which can be the case, like Flomax, and you get off the Flomax, sometimes you can get um, improvement in ejaculate. But PAE itself won't give you a more robust ejaculate on its own.
I've been answering some of these questions live as well as we move along.
Here's a good question. So there's a question here. How is PSA level affected? So that's a great question. So PSA will overall be reduced in the long term, with a caveat being that in the acute phase or immediately right after the procedure, it's actually going to spike and spill PSA. All the urologists at GBU know this, so they're not going to be checking a PSA immediately after. Doesn't mean that you have prostate cancer. It's completely related to the procedure. But as the prostate shrinks in total volume, which it will shrink about 30% in total volume, the PSA will reduce accordingly.
And there's one question on anesthesia. The type of anesthesia we use is called light sedation or moderate sedation. This means that you're not completely asleep for the procedure. We do give you some medications through an IV to help you relax as you're laying flat on a procedure table. And so you're relaxed for the procedure, you're conversant and able to perform some breath holds or let us check in on you. And folks do very well.
Will this presentation be available on demand? Yeah, so this will get emailed out to all the attendees and registrants, so you will have access to this presentation. Let's see, is there anything else we missed on here? So some of these questions are individually kind of oriented. So what I would encourage is, set up a consult with that contact information that Dr. Malik left up there, and you'll get that information via email. If there's any question or doubt, I'm sure Dr. Malik and Dr. Miller would be happy to see you and go over each of your individual cases.
I can answer a few more of these here, and I'll try to type
Sure.
some question answers in as well. One that's interesting is, what if you're unsure about the existence of cancer? So if you have a high PSA, that's a good question. It's one of the advantages of working with Greater Boston Urology is that they are the ones leading the charge on that workup. So, typically we will assess to make sure, is there a real risk of that? So if you have an elevated PSA, your urologist may want to proceed with a biopsy, or they may want to perform an MRI. Typically, one of those tests will give us the information we need to say, is there prostate cancer? Can we proceed? Or is there something that we need to address before? There will be occasionally patients who have what's called PIN, which is not cancer per se. It's sort of a precancerous lesion of low risk that can take many years, if not decades, to progress to something malignant. And we will occasionally do prostate artery embolizations in those cases, knowing that the patients will continue to be followed for progression of that.
So some of these questions have to do with post-surgery or post-procedure medication. There are temporary side effects as Dr. Miller had mentioned, and we do prescribe medications to help with these. And this includes a short course of antibiotics, a short course of steroids to help with the inflammation, other anti-inflammatories as well as medications to help with the mild burning with urination that can occur.
There's a couple questions here in the chat in regards to low-grade prostate cancer. So there's a couple patients who are on active surveillance or like Gleason 6, but with BPH symptoms. What are your thoughts on that, Hasham?
So this procedure, we can split that in two ways. So the presence of prostate cancer does not limit the ability to offer this procedure. Gleason 3+3 or Gleason 6 prostate cancer, low grade, the management of that depends on your discussions with your urologist. One can either undergo active surveillance or think about treatment strategies. But the presence of prostate cancer does not preclude this procedure, especially since we are targeting a different anatomy of the prostate when we are performing embolization. Prostate cancer typically resides in what we call the peripheral zone of the prostate. And when we perform the embolization procedure, targets what we call the central gland, which is what impacts the urethra and causes the symptoms from an enlarged prostate. Thank you for all these questions, folks. There are lots of questions that we're trying to answer at this time.
There's a few questions here about blood clots and chances of blood clots. So it's an ambulatory procedure, meaning there's not much downtime at all. Blood clots usually occur when you're bedridden or bedbound for an extended period of time, and that's not going to be the case here. So this isn't going to be a high chance for blood clots. There was someone here asking about stroke risk. With the access that Dr. Malik and Dr. Miller use for this procedure, the common femoral artery, the likelihood of stroke is almost zero related to this procedure. Now, if you were to go from a different access point like the wrist, then it would carry some risk for stroke, but here it's almost nil. Across all of our centers, over 25,000 TAEs performed, 0 strokes. So.
Yeah, there's again some individual questions that are personal to folks. So I would encourage you folks to reach out to individual urologists or interventional radiologists to answer some of these questions.
I see one question regarding kind of standard follow-up from this procedure, which is a good question. Once we do this procedure, you'll get a call from our nurses the next day. Make sure you're feeling okay. Make sure the medications all make sense. This is, in addition to what they'll talk to you before you go. Then you'll get another phone call follow-up from us at 1 month to see how your symptoms are improving. And you'll follow up with your urologist typically at 2 to 3 months after the procedure, at which point we'll have a good idea of how well it worked for you. And at that point, if they haven't started taking you off of some of your medications, they'll have that discussion and see if they can do that.
Some of these questions pertain to how many of these we have performed. I have answered this, but we have, in the past 3 years, with Greater Boston Urology, have treated over 2,000 men for this, for an enlarged prostate.
Yeah.
To put that into context, like that puts it, Dr. Malik or Shaman, 99.99% operators of this procedure. And he won't say this, but I will because he was my mentor and he's my good friend. They're extremely talented IRs. This is one of the most challenging procedures that you can do as an interventional radiologist. So even though it's something that technically you could go almost anywhere to get it done, you would want someone with a lot of experience doing this. And both Dr. Miller and Dr. Malik have that. And I don't think it's wrong if you see someone in consultation to ask them, how many of these procedures have you done? How long does it usually take you to do this? What is your success rates? Because I can say with full confidence, you will not find a better provider in Massachusetts for this procedure than Dr. Malik and Dr. Miller.
Yeah.
Thank you. That was very kind, Dr. Puyurappa. One question here that I'm also answering in the chat is, will a catheter be used during the procedure and how long does it stay in? No, it is not common practice for us to preemptively place a catheter. There are very rare circumstances where that may be entertained, but for the most part, unless you have severe challenges with urinary retention and that is an active problem causing infections and whatnot, we would not be preemptively placing a catheter. Those who do come in with the catheter typically have it in place for a few weeks before we entertain what we call a voiding trial.
I saw a question regarding preoperative workup for this procedure. Typically, the things that, again, it's another benefit of working with urologists is that they kind of have done most of the workup. So things that we like to know, what medications you've been on for your prostate, what are your symptoms. We'll typically get a sizing of the prostate, which can be done either by MRI or by ultrasound. But that's typically about the extent of what we need to know. And we'll ask you questions during the procedure. Additionally, have you ever had blood in the urine, things like that. But again, by virtue of using light sedation, we don't need to have a rigorous preoperative evaluation the way you would for a more involved surgery involving anesthesia. One question is where we do this procedure. We do these procedures in our outpatient offices in Plymouth and now in Framingham. They're little standalone medical buildings, not associated with a larger hospital.
Another question here is, will this reduce the chance of getting cancer? To our best knowledge, this procedure does not affect the risk of cancer, meaning it does not increase or decrease the risk of cancer. There are some clinical trials that are underway for using different injectables or materials that use the same pathway to treat BPH, to treat prostate cancer, but that's very premature. So to specifically answer this question, it does not reduce the risk of getting prostate cancer.
One question in here is there an optimal time and symptom progression to have this procedure, which is a good question. In a lot of cases, BPH is not a medical emergency, unless you have a catheter because you can't urinate or you're bleeding in your urine from the prostate. This is an elective procedure. So when does it make sense to have it done? Oftentimes, we'll have patients who've tried medication, Flomax or finasteride or similar medication, and either their symptoms have continued to progress or they can't tolerate the medication. And, it can sneak up on you. This is not a process that's going to, affect you right away. But, every once in a while, someone will be, I used to play 18 holes of golf, go out with my friends every weekend. It was no issue. Now I'm ducking into the woods 5 times around. Or I used to be an avid skier and, would go out all morning, get lunch, go all afternoon. And now every couple of runs, I have to go. It's things like that where if your prostate is starting to affect the way you are living your life in a meaningful way, then and you've exhausted medication options or you can't tolerate them, that's when I would think about, a procedure like this, which again, the recovery is pretty easy for it. And, it's a good option for patients like that.
Yeah, one question here is when does the prostate start to shrink and what size? In general, as we have counseled earlier, it takes about 3 weeks to a month for you to start noticing symptoms improving, and that's because the prostate starts noticeably shrinking at that stage. We typically say that it reaches its final size after embolization at the 3 to 4 month mark, which is why your symptom improvement should also continue in that time period. We've seen on average the prostate reduce in size by about a third, with a range between 25 and 50%.
Well, I think this was an incredible turnout. Thank you for everyone who joined. And thank you for those participating with questions. Thank you, Dr. Malik. Thank you, Dr. Miller, for hosting this event. We're really excited about offering this procedure to the community, and would encourage you guys to reach out. I think Dr. Malik had a contact slide, but you'll also get that through via email as well as this presentation.
Yeah, let me try and share that contact slide again. Let's see. There it is. So, as Dr. Miller mentioned, we have offices down in Plymouth and up in Framingham. And we have wonderful staff of schedulers, nurses, medical assistants, and technologists who would take really good care of you. We do have our email addresses here as well that you can direct to. You can speak to your urologist and talk to them as well. As I mentioned, we are part of the same practice, even though this is a collaboration between IR Centers and Greater Boston Urology. We have had really cordial and lovely relationships with our urologists at Greater Boston Urology and from the surrounding areas as well. So uh, feel free to reach out to your urologist or to one of us to answer your questions. I wanted to thank you again for your time. Dr. Miller, any comments?
No, I'm really pleased with the turnout. And if you have any questions about the procedure, this is how to reach us. We are open 5 days a week and we love doing this procedure.
All right. Thank you, folks, again, and we wish you a great evening.
Good night. Thank you.